morning, everybody, and thanks for the opportunity to come here and discuss my own complications. So if I have created the mess, I got to sort it out. That's how it works. So, uh, so, oh my God, it's not okay. So basically, we have a very elderly and quite frail. It's not showing up there, but it's okay here. So it's a lady who comes in with unstable angina. She has a limb-graft. I go in there. Her limb-graft is patent, and we did all this because there was a reason for it to be, done, as you can see. And I talked to her cardiologist who was in the echo lab. He came around. We looked at the pictures. He knew the patient much better than me. And then the decision was made, let's take her off the table. If I want to do ostial and proximal LAD, which involves a left main, we need to get the patient and family involved because it wasn't going to be a low risk. It wasn't a high risk, but it wasn't going to be a low risk. So, you got to accept and have that collaborative attitude with your colleagues. And of course, 85-year-old, mild renal insufficiency. It's always nice to think about, preserving the kidneys and not causing a damage. So that's what we did. It was all a 5 French axis. I do submit. This is one of the few cases where I did not do an ultrasound-guided axis. And if anybody can learn anything, this is this. And the reason why I didn't do ultrasound axis was because for some reason the ultrasound wasn't functioning. And for us, the standard is ultrasound-guided, axis. So I tried to deploy the 6 French per glide, and I have done thousands of them, so it's not that I needed to think about it, but somehow it didn't work. And probably I was hitting on a calcium, shelf on the anterior wall. I don't know what actually was happening there, but somehow I just could not. Thankfully, I felt that, in this case, I will just take the device out, and I retrieved everything, leaving nothing behind. Everything was okay, and it was a busy day for me in cath lab. And of course, it will happen exactly on the day when you don't have time and you are trying to do too many things. That's the, Murphy's Law. 30 minutes later, as you can see, her symptoms and signs are very much suggestive of somebody who has a class 2A, at least class 2A. She hasn't yet progressed to class 2B, so we need to act fast, and we did. We brought her back to the lab, and if you look at this picture, you can make a sense that it is my doing. I have done something to the right common femoral artery. I'm not really unhappy with this, but this picture made me sad, really, really sad. Now, anybody who is in their early stages of career, keep this image in mind and why it made me so sad. Not because I have a complication that happens to us all the time, but the way the artery looks here, it tells me that it's going to be a long day. And I'm not really sure at this point if I'm going to be able to successfully. And I'm one of the, big-time CTO operators for the lower limbs, upper limbs, places you name. But the moment I looked at this picture, I knew I possibly have transected the artery or traumatized the artery in such a way that I might not be able to. And I wasn't wrong because really, I tried for 45 minutes. After 45 minutes using lots of wires, I probably exhausted all the hydrophilic wires in my lab, 035, 014, multiple supporting catheter. Thankfully, I managed to get in profunda. I'm feeling good at this point. Now look at this. What have I done? It really looks very nasty. Anyway, so I went with a escalating balloon approach, and at this point, it does feel like, it was a bad day, but things are looking better. So, I am much relaxed, less sad, not happy, but less sad. And then, of course, whenever you have something like this, you go and look infrapopliteal. Now, when you look at this, you keep on waiting, and if you have to wait for the artery to show up, that's not a good sign, as we all know. There's a huge thrombus burden here, and see, of course, it doesn't have a flow. Thankfully, I was able to use, TPA. This is the picture from the next day. At this point, I feel really good about this situation, that, what was a catastrophe in my hand is not going to be leading to another catastrophe, which is an 85-year-old, frail but independent woman going to lose her limb. That is one of the saddest things which can happen, losing your independence. And as you can see, we do have some distal vessel flow. I wasn't aware of her PAD when I actually took her to the lab initially. And then, one can argue that, there was no need to actually work on the, TP-tron, but the fact is that, ET is occluded, peroneal is occluded. Yes, I do have a reconstitution flow by 2 vessels. So, I did just a soft balloon angioplasty that might not have made much of a difference because there's a significant recoil. But maybe some of you will agree with me that there is a better flow to the foot. So, and this, the SFA profunda looks great. And this is a much better scenario than what it was, last night. And this picture basically looked like, why was I fussing about anything? Things look really good, right? So as you can see, this was a case which was my own, doing. And it took me a long time to figure out why it actually happened. And the answer I got was just, last month. I was talking to some of my colleagues in C3 where they presented similar complications. And what I understood from them is it's the foot plate which actually gets entangled when you are trying to deploy it. And for most of you who are training now, I think most of you are being asked or trained that when you are deploying the perclose, you pull it up slightly. Although you're getting an access at 60 degrees with an ultrasound and a micropuncture, hopefully, but when you deploy the perclose, lift it up and try to deploy it at a 45 degree. I don't have the cartoons to actually explain, but what is actually happening is that if you deploy it at like 60s or less than that, you have a potential. You have a potential to actually cause more foot plate trauma than what you do when you pull it up slightly and deploy it at 45 degree. So that was my learning.
I'm going to have to stop you here because we're out of time. Thank you for the presentation. That was a good case. I've seen a couple of these complications. There's not enough time for discussion, but one question: did you take a femoral angiogram before you deployed the perclose? Because that SFA in common femoral artery looked very calcified just on your digital images. I would have personally not even attempted the perclose there.
Yes, and that is what I think that one thing which I learned was that this was one of the few femoral axes where I didn't use the ultrasound. This was one of the few femoral axes where I was fooled into believing that I could deploy the perclose, and this is what happened. So even if the angiogram looks okay, because the imaging quality can vary from lab to lab, machine to machine, and I will submit to it that we don't have the best optimal imaging. So the imaging was actually good in terms of position of deployment, but without ultrasound, I wasn't able to appreciate what was the anterior wall calcification.
Okay.
And that's where I failed.
Thank you very much for presenting this case.